Hello, good afternoon, all of you.
Good afternoon, Dr. Pius.
Good afternoon, Doctor.
Na wasalimu kwa jina la Jamhuri ya Muungano wa Tanzania.
Kazi iendelee.
Tunawakaribisha kwenye darasa letu la leo la masterclass ambalo litaanza muda si mrefu. And today we'll be having the gurus of emergency medicine in Tanzania who will be speaking and sharing their experiences regarding the basic emergency care at the primary health facilities, and they will really tell us what is exactly needed. Kwa hiyo tunapoendelea kujoin, tutakuwa na moderator ambaye atakuwa ni Professor Kaushik Ramaiya ambaye ana uzoefu mkubwa sana, is a physician and having various experience in management as well as administrative issues, and has a lot of publications. Lakini pia tutakuwa na wazungumzaji wengine. One will be Dr. Juma Mfinanga. Another one will be Professor Henry Sawe with Dr. Sonda Shaban. Kwa hiyo tuendelee kujoin na Zoom ya leo. If you will active participate, we have already spoken to the Medical Council of Tanganyika, so we'll have an opportunity to award the CPD points for those who will active participate. So nawakaribisha sana. In 10 minutes to come, tutakuwa tunaanza session na nitakuwa ninamkaribisha moderator wetu Professor Kaushik ambaye ndo atamoderate our Zoom meeting today. So please stay tuned. Asanteni sana.
Kujiridhisha
Hello, good afternoon. Good afternoon again.
Good afternoon.
Good afternoon.
Afternoon.
I would like to appreciate the presence of Professor Koshik. Professor, good afternoon.
Good afternoon. Thank you. Thank you
Welcome
for
to our
inviting.
today's masterclass.
Thank you very much.
The one who is talking, Dr. Pius from the PHC, who is coordinating these masterclasses that you have been doing since the month of January. But again, I appreciate the presence of Professor Henry Sawe. Professor, good afternoon. Professor Sawe, good afternoon. Dr. Juma Mfinanga.
Yes, good afternoon.
Good afternoon, Doctor. You are welcome to our today's masterclass.
Okay, thank you very much.
I can see the participants are continuing to join our platform. Up to now, we are almost 62. So we are.
Good afternoon. Can you
We
hear
are
me?
about to start. 5 minutes to come. Professor Sawe, good afternoon.
Good afternoon. Sorry, I've been having some audio technological problems, but I'm just migrating to another device. But I'll be ready shortly. Thank you.
Okay, you are welcome. Dr. Sonda Shaban. Good afternoon, Dr. Sonda.
Good afternoon, Dr. Pius.
Welcome to our today's masterclass.
Thank you very much.
With all the participants, today we will be pledged to have our Honorable Deputy Minister from the President's Office, who is dealing with the health, Dr. Festo Dugange, will be joining us soon, but he has other commitments right now, so we'll have to start soon as possible, and when he joins, we'll appreciate his presence. But again, we'll be having our Director of Health, Social Welfare and Nutrition from the President's Office. Good afternoon, Dr. Nturi. You are welcome.
Thank you very much delighted to be part of today's session. I am in the field. Nevertheless, I'm glad that you were able to reach out to our distinguished speakers. So I place the session of today, and I'm quite hopeful that every participant will get to enjoy today's session, which is very pertinent to what is going on in the primary healthcare level as far as the government investment in the area of emergency care. So I'm very much delighted, and I wish all the presenters, including the moderator, the very, very best session of today.
Thank you very much, Dr. Nturi, for your wishes and your good remarks upon all the participants of today's masterclass. We appreciate your presence and we understand what you are doing upon the supervisions in the regional health management team across some regions of Ruvuma, Pwani, Dar es Salaam, and Morogoro, which you have been doing for the past 2 weeks. Thank you very much.
My pleasure, my pleasure.
So online again, I can see Miss Amina Mfaki, who is the Assistant Director at the Pure Raj. Madam Amina, you are welcome.
Hello. Thank you, Doctor. Thank you very much. Hello, Dr. Piusi.
You are welcome, and we appreciate your.
Thank you, thank you.
We appreciate your presence, Madam Amina.
Thank you, Doctor. Thank you very much.
So we have a good number of participants. So as right now, I would like to welcome Professor Kaushik, who will be moderating our today's masterclass. As I have introduced you earlier, Professor Kaushik is a consultant physician, but again is assistant a medical administrator at Shindmandari Hospital in Dar es Salaam, Tanzania. He has a massive experience and holds several honorary appointments within various foundations, including the World Diabetic Foundations, but again, the Tanzania Diabetic Association. Professor Ramaya has been main inspiring of a project responsible for various areas in Tanzania, but today he will be moderating our session, our Zoom masterclass, and he will be responsible to take over and the full introduction of all the key speakers. And as we said, our guest speaker today will be Dr. Festo Dugange, who is the deputy minister in the president's office. As right now, he has other commitments. So when he will join our Zoom meeting, I will let you all know. So Professor Kaushik, please, the platform is yours. And I take this opportunity to welcome you and start the session. Thank you.
Thank you very much, Dr. Pius, and good afternoon to everyone. And I would like to thank Tamisemi for giving me this opportunity to moderate this session. I think we have got excellent array of speakers, and I'm sure that all those who have logged in will learn quite a lot on what is actually happening at emergency care. Our experience with the emergency care at the primary care, when we did an assessment about 5 to 6 years ago, there was hardly anything which was happening at the primary care. And emergency medicine as a terminology was just a terminology without any infrastructure in place. And now, as we have seen over the last few years, there's been quite a lot of infrastructure which has been built in, at the same time, a lot of training going on. And there's a lot of, I would say, initiatives taken at the primary, secondary, and tertiary levels. And we have excellent speakers in Dr. Juma Finanga, Professor Henry Sawe, who are the gurus of emergency care in this country. And I'm sure all of us are very eager to listen to them. But first, we'll have Dr. Sanda Shaban from TAMISEMI, who will give us a perspective of the TAMISEMI's role and what they have been doing at the primary and the secondary level to initiate this emergency care. So Dr. Sanda Shaban, welcome, please.
Thank you very much, Professor Kaushik. Good afternoon, everyone. It's really a pleasure for me to participate in this masterclass and be able to share what PRAG has done so far with regard to basic emergency care in primary health care facilities. My name is Dr. Sonda Shaban. I'm working at PRAG, a Department of Health, Social Welfare, and Nutrition as coordinator for primary healthcare infrastructure development. I really feel honored to be one of the speakers today in this masterclass. And without further delay, I would like to take you through what I've prepared for this masterclass.
Dr. Sanda, before you proceed, just to be fair to everyone, we'll give each speaker 15 minutes and then we'll have 15 minutes for discussions. So you can proceed. Thank you.
Oh, thank you.
You can proceed, please.
Thank you very much.
Dr. Sonda, you can just let me know to move the slides. Thank you.
Yeah, you can move the slide, please. Professor, you can move the slide.
Yes, I've just moved it. It's showing presentation layout.
I'm not able to see.
Which slide can you see?
The first one, emergency and critical care services, the title.
Already moved with them slides.
Okay, let me see what I can do.
So I'm gonna redo again. Let's just stop sharing and then I'm gonna share again.
Okay, thank you.
Can you see now?
Not yet.
Takes time to come on.
Let me use my slide.
Usually
Okay.
takes few minutes to come along.
Yeah,
Yeah, you can see this.
there we are now. Yeah, this is the presentation layout. Basically, I'll take you through what PRAG has done so far in terms of physical infrastructure and what is the plan for what we are planning to take of these emergency and critical care services in primary health care facilities. Briefly, I will take you through the introduction. We'll see how far PRAG has gone, where we came from, and we'll also take you through also share with you the status of implementation so far with regard to construction of EMDs, ICU, treatment center, Kasuli and staff houses. We also share with you the training plan which we have prepared and the challenges which we foresee, and then we'll finish up with a way forward or what is really needed, what kind of support we think we really need to make sure that these services are comprehensive, being delivered at the primary health care level. Next slide, please. In 2017, PRAG launched a special program or strategy to increase access and availability of primary health care services in local government authorities. After doing a thorough assessment by then, we came to realize that the infrastructure for primary health care service delivery was not adequate in terms of number, also in terms of the quality and the availability of these essential healthcare services. In your left side, you can see the strategic plan, which we launched in October 2017. We have several objectives, but number one was to make sure that the available facilities are able to give services to the required standard. And by then we had 77 cancer hospitals out of 184 cancers. And even those 77 cancer hospitals were not up to the standard as per requirement of the Ministry of Health. With regard to health centers, we noted that we had 535 health centers which were providing services, but most of them, the services which were being provided was at the level of dispensary. Out of these 535, only 115 health centers were able to provide comprehensive emergency, obstetric, and neonatal care services. By then, we didn't have any cancer hospital, which were providing emergency and critical care or ICU services as per required standard. Next slide, please. So, as I mentioned, emergency and critical care services was not a priority for PRAG. Remember, we had a number of health facilities, health centers, which were not be able to provide services. So this was number one goal, but also to expand referral services by constructing hospitals in cancers which did not have hospitals. So it's still 2020, when we faced COVID-19, is when we came to realize that our physical infrastructure was not adequate to be able to face COVID pandemic. Next slide, please. So in 2021, PURAG through IMF Fund, we were allocated with 203 billion. With some of this money, this fund went to establishment of emergency and critical care services in primary healthcare facilities. And we were able to construct 8 EMDs, 28 ICUs, 21 oxygen plants. 8 came through Global Fund, but also the fund, through that fund, we have procured medical equipment for ICU and EMD, but also we have procured 316 ambulances. Next slide, please. So just to share with you the status so far of implementation. With regard to EMDs, remember we are constructing 80 EMDs. Out of those 80 EMDs, 58 already completed. We're just waiting for installation of oxygen. 32 out of 80 are at the finishing stage. We also had 28, we have constructed 28 ICUs, which we have already finished, which 24 out of them have already completed construction. We're just waiting for the oxygen installation and other gases. With regard to treatment center is already complete. This treatment center for infectious diseases is being constructed at Kasulu district, in Kasulu district council at Kasulu district hospital. But also through that fund, we have also constructed 150 staff houses, which 128 of them has already, we have already completed the construction. Next, please. So together with the construction of these EMDs and ICU, we also planned for training in collaboration with MUAS and Ministry of Health. We have already done arrangements. We're just waiting to start in March, and we expect by then the installation of medical equipment and guests will already be complete, and staff will be able to start right away after coming from the training. We proposed 5 staff from each facility should be trained, which is 2 clinicians, 1 anesthetic, and 2 nurses. However, we believe for the 3 weeks, which they will be in training, is not enough to learn everything. And we really think that they will need continuous mentorship and coaching. Next slide, please. So these are the challenges that we are facing currently. We lack emergency medicine physician at the council level. I'm not quite sure if we have enough at the regional level. Professor Sawe and Dr. Mfinanga, they might be able to share because they are in training institution. But also shortage of skilled staff in general. We know we have deficit around 40-something% of skilled staff in our facilities. Now you can imagine we are starting this new department, which will also need to have staff will be stationed there throughout throughout once the service started. Also, we foresee, we have inadequate knowledge and skills in the management of emergency and critical care services. Here we mean that once you open these services, you start delivering these services, the skills, the knowledge, the experience on how to run emergency services continuously, and being able to deal with the challenges that come across, and everything needed to make sure that this department runs smoothly. But also, what we really need to plan well is maintenance and infrastructure, maintenance of physical infrastructure and medical equipment. I believe Dr. Finanga will be able to share what is the experience at Wimbili when they started. But we believe that we really need to have a biomedical engineer who can be found whenever is needed, once there's a troubleshooting with regard to medical equipment, but also physical infrastructure. If there's any fault with regard to the building, that might risk these services not to be given the optimum as per requirement. We also see that we will need continuous mentorship and coaching for staffing working in this emergency department and ICU, emergency and ICU department, as I mentioned before. Next slide, please. So what is needed? We thought, PORAG, we thought that we really need policy change to allow specialists, not only emergency medicine specialists, but specialists in general. We are opening now maternity wards at the council level, in council hospitals, and we really need specialists to be there. We have expanded the referral services. We see that this is high time now to have the policy change to allow specialists to work at the cancer level. You know, now when medical doctors go for specialization, when they come back, they have to shift to the regional or national level, because the policy doesn't allow them to continue to stay at the cancer level. So we really think this we really need to change, and we have already communicated with the Minister of Health, and we believe that this will be taken care. We think we really need to increase production of emergency medicine physician. Professor Sa will be able to share, because we see the gap, and now COVID-19 has already showed us that we really need to prepare to have these specialists at even at the cancer level. We know now we have biomedical engineers who are not employed. I'm not quite sure about the number, but I believe that if we employ them, we can be able at least to make sure that we have 2 biomedical engineers at the regional level, if not even at the council level, who will be able to plan plan for services of this medical equipment, and go through the councils, making sure that these medical equipment are taking good care. We have procured a bulk of medical equipment, and it's a huge money, really. And to be sad to see this equipment stop working after a few years. So we really need a good PPM plan for both medical equipment and physical infrastructure. We see that we need continuous mentorship and coaching, as mentioned, and we really need to strengthen the referral system from bottom up with regard to accessibility of the facilities in terms of roads, being able to access in terms of ambulances, and also communication. Before even the ambulance take off from the initial facility first point, before even reach the destination, there should be a communication. Those clinicians at the next point should know the kind of case that is coming and prepare everything. Next slide, please. So thank you very much, and let me invite my my colleague, Professor Sawe, to continue.
So thank you very much, Dr. Sando, and for the participants, if you have any questions, please make a note. And after all the three presentations, we will be basically keeping a floor open for the questions. I would like to welcome Professor Henry Sawe, who is Associate Professor of Emergency Medicine at MUHAS. And he has also been one of the first, I would say, professor within the emergency medicine component. At the same time, he has done quite a lot to build the infrastructure of emergency care in this country. So, Professor Sawe, karibu.
Thank you very much, Professor Kaushik. I really appreciate the opportunity to be able to provide some technical input to this presentation. And I would like to appreciate also the opportunity given to us to be able to advance emergency care systems within the country. And also like to thank Dr. Sonda for giving that very nice preamble. So I'm going to give the first part of the talk, and my colleague, Dr. Juma Finanga, will give the second part of the talk. The first part of the talk, I'm going to speak more broadly about the emergency care framework. If we look at our title, the title requires us to explain what is really needed in terms of emergency care within the country, given a very big infrastructure input that the government have already put in, what exactly that is needed. First of all, I thought it would be very important to align everybody's expectations by first starting by defining what emergency care is. I think there is usually a confusion for most part what emergency care is, and I thought I would start my talk today by just narrating very briefly what emergency care is. You'll see in my definition, there are texts that I've highlighted in red and yellow and green. And basically, whenever you speak of emergency care, regardless of the location, regardless of where you are, it's all about the 5 components. It's all about providing the triage to the patient, which is timely. Remember, timely is key. Providing resuscitation, diagnosing the condition that the patient has appeared with, treating it, and then disposing this patient, and whether disposition can be operating theater, ICU, or referral. And this has to happen for the patient who are presenting with medical or non-medical emergencies. And to put this into context, for example, if somebody appears to an emergency care in any district or council level unit and have a seizure or convulsion, the resuscitation in that situation, for example, will be giving diazepam. And then the next phase, once the convulsion has stopped, is diagnosing why is this patient having convulsion. It can be a rapid diagnostic test to give to say this is malaria. And when we say initial treatment, then it becomes giving the first dose of anti-malaria. And then this patient, since he's already having seizures, disposing this patient to ICU. Now, I understand this is just a very basic contextual understanding of everybody, but most of the time, the expectation of what emergency care is sometimes goes beyond what is defined here. And remember, emergency care can start not within the facility, it goes beyond the facility, but it has to do all these 5 components, regardless of the locality. Now, it can be, it is on the scene. Let's say there's an accident on the scene. Whoever appears there needs to provide rapid triage. And if there is capability to resuscitate the patient, whether it's just going to be a splint by using a tree or a splint by using a box that's around, and then diagnosing and say, I think this person has a femur fracture or this person has a head injury, then the initial disposition will be taking this patient to a nearby facility, and maybe others will be walk away. So emergence care encompasses that framework, and I'm going to talk about that in a detail in the next slide. Now, as we speak of emergence care, it's also important to speak of what emergency department is. And an emergency department in other places, as you will see in this slide, it is also called casualty, emergency department without a medicine, emergency room or emergency unit. Whatever the terminology is, for our understanding or scientific understanding, emergency department, casualty, emergency room, emergency room, whatever it is that you call it, it has to be a special area within a health facility that is dedicated for providing emergency care 24/7, 7 days a week. So 24 hours, 7 days a week. And it's important to notice here that this has to be a special area, and it can be any area that is designated to do that. It has to have the capability to do the 5 things that I've mentioned in the previous slide. Now, I go to the framework, it's also important to appreciate how do people access emergency care. And again, this might sound very basic, but we usually sometimes combine and mix things in the process. Usually, anybody having an emergency can be anything ranging from an acute abdominal pain, a child who has high-grade fever, a pregnant mother who is bleeding per vaginal, or is an injury, let's say that due to road traffic accident or a fall. Usually, it can happen in 3 ways. One is either a person accesses the system by going through a pre-hospital service, and that's the ambulance part, activating the ambulance part. It can be a formal ambulance system, or it cannot be a formal ambulance system. You can just call a taxi, a Uber, a bicycle, a motorcycle. That activates the system to take the person from that area, and that's how you access the emergency service to a facility. We've seen it, what's been done very well with the a MAMA program, where the taxis are used to activate people to go to an emergency setting by just making a phone call. That's one way. The other second part is somebody can just show up to a primary health center by just walking in themselves. And this is probably the most common, and walking in not necessarily by legs, but just moving through the system, getting into the primary facility. In other situations, people shows up to tertiary level care, like Dodoma Regional Referral Hospital, or Benjamin Mkapa Hospital, or Bugando, or Muhimbili National Hospital. These are 3 main ways in which people access the emergency care. Now, it's important to take a deep dive on the framework and to understand where we are in terms of our context here in Tanzania. As I've said again, an illness usually happens at the scene, and the scene not necessarily can be in the road, it can be at home. A child has high-grade fever, or a child just burnt to the leg, or the child just fall, or a pregnant lady just started having pelvic bleeding. In most developed settings, when you speak of emergency care system, there has to be a system that can provide the 3 components that are in this slide. There has to be a bystander. If it's home, it can be a family member, a good neighbor. If it's on the road, it can be a bystander. There has to be a way in which this person can call a system, and that system dispatches an ambulance, or dispatches a vehicle, or dispatches a provider, whichever mechanism. And that provider is able to reach to the scene in time and be able to provide the care while the patient is on the scene, and as well as the patient being taken to the facility. This is very important because this is where most of the time the delays leads to a poor outcome down the road. And in our context right now, as we've heard from previous speaker, the government have purchased a good number of ambulances, about 360 in the council level. Now, having an ambulance is one thing, then having a system that activates that ambulance is another thing. And I think that's where probably our focus as a country and as a government should be, like having an ambulance that is able to be activated to respond to emergencies that happens, either it's on the road, either it's at home. It takes time to get there. It takes a lot of resources to get there. But I think if we're able to get there, we'll already break the first cycle of delay, and that's a cycle of sin. The second component, which is what I've just alluded to on this framework, is the transport component. Now, transport component is just not a transport system, it's a system that has a transport mechanism that's an ambulance, a provider that is sitting with the patient and able to provide resuscitation care, and also a system that's able to get to the nearest by facility rapidly, quickly, but also safely, and then hand over this person to another person. There is usually a misconception that once you have an ambulance, then you already have an EMS system, but in actual sense, an ambulance is an integral part, but it's just a very small component of the system. You need a mechanism to dispatch that system, and also a provider to provide care, and also a destination, which is the next slide, the facility. You'll see this slide is broken down in through levels. And the first level is at the very bottom where the provider is, provider that receives the patient. That's where in-facility emergency care starts. Remember, the triage has started at home. The in-facility triage starts here. And then this provider is able to then say, okay, based on the condition, this person needs to receive X care or Y care, etc. Now, putting together, and I'd like to acknowledge this framework which is coming from the World Health Organization, is the framework of emergency care system that as a country, we were also able to contribute towards development of it. Is the 3 slides that I've already shown put together. Is you move from the very left of my slide, which is the pre-hospital or the scene, to the transport mechanism and to the facility. This is what we call emergency care, and this is what we need as a system. Now, we have pretty much every pieces in our country. We have now renovated emergency units. So we have done the right part. We need to upgrade the skills of the providers that are providing services in the emergency unit. We've procured ambulances. We need to upgrade the capability of the ambulance to respond. But then there's a component, which is a technological component, but also the community technology, that people's mindset as a cultural needs to change to be able to raise the alarm for the emergency as soon as possible. Now, this is the overall emergency framework that is applicable across the world. As a country, we pick which pieces that we have, which pieces we are missing, and we feed in according to our context and our resources and what we need to achieve. Now, the next few slides, I'm just gonna allude to why is it important to focus on emergency care. And we can speak about many things, but ultimately, our goal as providers is to make sure the patient comes and we get a very good outcome. Now, it's not always the case that we get a good outcome. There will be situations where a patient will come and an outcome can be bad. But how do we get the patients to get the outcome we need? Certainly, we need to have disease-specific treatment and procedure in place. And this is what most of the focus and most of us, we know that we need to be very oriented to know what is the illness that the patient has. For example, to be very specific when it comes to treating malaria, morbidity and mortality decreases. We need to be very particular towards managing childhood pneumonia so that the upper respiratory tract infection, morbidity and mortality goes down. The same. That is important. That is what we've done. That's what we do. We all know that patients do not come to us and say, you know, I have pneumonia, I have malaria, I have subdural hematoma or ectopic pregnancy. Patients do not show us to us like that. They present to us, and also they do not know. When they come to us, they do not know that I need oxygen, or I need ICU care, or I need antibiotics, or I need X-ray. They do not show up to facilities at a council level, at a regional level, and say, I'm here, I need oxygen. I'm here, I need antibiotics. No, what we know as providers is patients show up to us with symptoms. Most of the time they'll say, I have fever, I'm injured, I have a difficulty in breathing, I have low abdominal pain. And then as a system, we need to take what the patient tells us and put it into time-sensitive approach, take it into a time-sensitive triage, take it into time-sensitive management so that you are able to reach to this goal of a disease-specific treatment. Now, if we don't combine the symptoms above to approach the patient in such a way that we're able to meet the disease-specific treatment, then no matter what we do, the outcome of the patient may not matter. And that's where the emergency care comes into the play. So the emergency care brings the patient from what the patient has all the way, combines what the patient is saying, putting it together, diagnosing the patient, and then saying, okay, I think this guy has malaria. And then from that standpoint, the malaria treatment starts and goes on to the internal medicine folks if he's an adult, or to pediatric if he's a pediatric patient. If you don't have a robust emergency care system, you're likely going to miss that interface in between. And the patient with fever, and the fever can be due to ruptured intestinal obstruction, that patient may be admitted to internal medicine because we think it is malaria, and so forth and so forth. And so that's why we have to really focus very well into why we need to have a robust, and not just emergency care, but a robust one that can help us navigate this depiction that I've put forward. Now, beyond what I've said in this slide, which is just showing you where an emergency care fits into our system, there's quite a lot of evidence out there that I'm going to share in the next few slides. Number one, the disease control priorities that's produced by the World Bank as well as World Health Organization have shown that if our emergency care system are robust, we can address up to 54% of the annual deaths that we have. And on the right side of my slide, I've shown you the disease conditions that can be addressed, a number of deaths that we can evade across the low and middle income country. And Tanzania is a low middle income country. Obviously, most of these conditions, as you can see from the diarrhea disease, respiratory tract infection, malaria, these are all the disease conditions that we deal with on our day-to-day basis. And when we say an emergency care system, we mean the system that I showed you the framework before. Similarly, and I really like this slide, I know you may not be able to read the box on the right, but I just put it there for future reference if people are going to access these slides. The Sustainable Development Goal that have been put forward by United Nations, the emergency care system addresses almost all health-related sustainable development goals. You can see in the slide I put on the right, and as an example, if your eyes could see, one of the goals, which is number 3.1 for health, is by 2030, we are expected to reduce the global maternal mortality rate to less than 70 per 100,000 live births. Now, emergency care interventions, which includes treatment of obstetric emergencies such as hemorrhage, hypertensive disorders, and sepsis, if we treat that, those are like top 3 killers for maternal patients. And if we're able to manage those, you can see most of those are emergency. If our systems capture those and manage those, definitely the maternal mortality is gonna go down. Another one, which is number 3.4, which is by 2030, reduce by 1/3 premature mortality from non-communicable disease through prevention and treatment, and promote maternal health and well-being. Interventions that include treatment of exacerbation of this condition. So we know most of the non-communicable conditions like asthma. If we manage status asthmatic in emergency department, that's how many patients with asthma dies. If we manage exacerbation of COPDs in emergency department, if we manage patient with stroke, we mitigate the impact of stroke, which includes aspiration pneumonia and early recognition with the system for ischemic stroke, early thrombolytics. If we mitigate that, we definitely are going to reduce the number of people who are going to die. But it starts with the emergency care and then moves on to the definitive care. Now, it is unlikely we will be able to meet the Sustainable Development Goals if our emergency care system is not strengthened with the framework that I've just described. And I'm just going to finish up with, this is something that was done locally. Also, upon the starting of the opening of emergency department at Muhimbili National Hospital was associated with a significant decrease in hospital mortality 2 years down the road after the department is opened. Now, this is just one of the impact that you can have with emergency care. There are many other associated impacts when you have emergency care, which includes but not limited to improve the customer care, improve the patient satisfaction, improve provider satisfaction, and many of these ones. And I would like to pause here and hand over to my colleague, Dr. Juma, who is going to speak more broadly of what is available in the country, what can be done within the framework that I've just shown you, and within the importance of the slides that I've presented. Again, thank you very much for giving us the opportunity to share knowledge. And also thank you, the chairperson, Professor Kaushik, for fantastic moderation. I will hand over to you, Professor Kaushik. Thank you.
Thank you. Thank you very much, Professor Sabe. It was an excellent overview. I think Dr. Sando presented the infrastructure which is putting in place. And I think you have highlighted the importance of using that infrastructure effectively if we are to achieve the goals of what we call as an SDGs, but at the same time, ensure that we provide a real emergency care on the ground. Our next speaker is Dr. Juma Finanga, who is the head of emergency medicine department at Mumbili National Hospital. And I think he's the person on the ground, and he has been actually, he's elevated emergency department at Mumbili to a very high level. And let's hear from him, what are the challenges and what are the successes he has attained. Karibu, Dr. Juma Finanga.
Okay. Thank you, Professor Kaushik, for nice moderation. And thank you, my colleague, previous two speakers, Dr. Sonda, Professor Sawe, for opening this discussion. And thank you, Tamisemi, for organizing these master classes and including us as the speakers for talking about emergency care in this country. Thank you very much, PHC. Thank you, Dr. Ntuli, and all other people who have been involved in preparing this session. But all in all, I'll appreciate the presence of all attendees who came for this masterclass training. As I have started that, my colleague have already said about what has been done in Tamisemi, and the professor has been talked about the framework of emergency care. As you know, that emergency care is very wide, and I cannot talk much. If you want me to talk about emergency care, it may need years and years to talk about it, and I have a lot of things to talk about you, but I'll try to put just a snap about awareness about how can you see a lot has been done by Tamisemi to build infrastructure, a lot has been done to bring things in a primary health care. But what I'll be doing for you, just giving a brief on what can you do in making sure that the facilities which are already opened or others have been opened, which are running, how can we make them operate nicely, and how can we at this end support you to make sure that all these areas are operating well. Can you bring the next slide? So before going to that, I'll just mention some few things showing that these are fact issues you have to know. And as you know that primary health care system is a crucial and is a fundamental of everything when we talk about healthy. And these are some facts which we have in our country, that we have a population now around 62 million people, and the majority of these people are at the primary healthcare. They are seeking the service at the primary healthcare services. And the female to male ratios, according to our data, it may be 1:1. They may vary somehow, but if you take the average is 1:1, and our life expectancy is 65 years old. And all this 65 years because of a lot of diseases which you have, and having the poor emergency system, which cannot guarantee you to get well emergency care services, and our maternal mortality rate. Now, I think this number may not be right, but I think it was around 556, maybe change according to data, which always be updated by the National Bureau of Statistics. And the HIV prevalence now, I think it remains 5%, if not reduced a little bit, but it's around there. It was around 4 to 6%, maybe 5%, yes. And the leading cause of the death in all age in this country has been reported in a lot of data in this country. HIV is leading, and then respiratory infections, especially for the under 5, malaria, diarrhea disease, and the perinatal condition and trauma. All these are the factors which we have in this country. And this slide, I think Professor Sawe has been spoken about it, but I want to make you and emphasize that where we talk about emergency care and where we're saying the emergency, emergency care is important. It's because an emergency medical system have a potential to address now is around 45 to 54% of death occurring in the low and middle income country. Professor Sawe spoke about this, and that's before the last slide of Professor Sawe, he talked about this, that if you put an emergency care system very well, you have a chance of addressing more than 45 to 54% of death. So is how can we say the value of emergency care it has in all hospitals, especially in the primary health care. Next slide. And coming to our context in Tanzania, I think Dr. Sonda talked about this when he was saying that when we are saying emergency medicine is that we can say it is in infancy, because up to until 2010 we had no formal emergency care. The emergency care, Professor Kaushik, he knows that we had a system of emergency system which was not as format as proper how emergency care is needed, and Tanzania had no formal emergency medicine care until 2010. And in 2010, we're coming to next slide, you see, is when we found that there is a need of opening an emergency department in this country. And we can say thanks to the government, Ministry of Health and the Abbott Fund, who came to Tanzania in those years in 2010, and they opened a full capacity emergency medicine department at Muhimbili National Hospital. And this was opened in 2010 for purposely to make sure that at least we are trying to address those things. And at that time, you are seeing the President Jakaya Kikwete was the president at that time who opened the first emergency care in this country. And we found that when we started in the same year, we cannot sustain the emergency care. What we did in that year is when we said, let us have a system which can make the emergency care services to stand in this country. And the same year, an emergency medicine was established, a new specialty in the country. And this program was tailored in the local context. It's the only country in the world which you have a training program which has been tailored in to address our local context, our local problems. This was based on the emergency research addressing Tanzania needs. Sometimes people they run the program which always doesn't address the local context of the country. So we decided to open.
Dr. you are having a very bad echo. If you are using two items, do you mind to plug one, or if somebody else is doing that?
Moderator, can you find somebody who's talking Zena Mtuju? Okay. I think now it's okay.
Yes, please.
All right. So in 2010, we opened the program of training and emergency medicine so that we can make sure that this program is running properly. Next slide. Next slide, please. So I think this slide has been spoken by Professor Sawe. I don't have to speak again about the slide because it was already spoken. But coming to now, why are we saying, and this is a very nice slide which will address everything about what we are talking about, having a sustainable emergency care services. As Dr. Sonda said that we have already renovated and building a lot of emergency medicine in the primary health care. But in order to operate this emergency department, we must have all these 4 components. And the first component, which I want you to know, is about having the so-called a professional development. We must have a formulate and develop clinical cadres. We know that in emergency care, we must have all cadres which are needed to run an emergency department. We must have doctors, we must have nurses, we must have social worker, we must have accountant, we must have medical recorder, we must have health attendant. All these are professionals which has been needed to be developed in having a sustainable emergency care at any time. And another area is about the HR investment. I think Dr. Sonda talked about in challenges in when we are talking about having an emergency department or emergency care in a primary care about shortage of staff. But we must have developed anybody who has an emergency department, he or she must develop a champions. And this champion must make sure that they are running the show at the site. And this is how can you operate an emergency department? You cannot operate an emergency department if you don't have a champion who to operate that an area. And the second issue is about supporting the staff capacity building. Always in emergency medicine, always diseases come and always we learn new diseases. In 2020, we came to learn about COVID-19. COVID-19 was a very new disease. Now there is Ebola, and there is a lot of diseases which always come as an imaging and re-imaging diseases. So we must support a staff capacity building so that we can run an emergency department. And also in emergency department, we must have a motivated staff. Always, as they said before, we must have a motivated staff. Why? Because as you know, an emergency department is a place which operates in 24/7 and cannot allow it to be closed at any time. So we must have very good staff which is motivated to work in emergency department. And remember, emergency department is the, we can say, is the door of your house. If you have a very good emergency department operating, you are sure that your hospital will be calm and your service will be highly developed. And in order to have this program, you must have a financial sustainability. So you make sure that at least if you have an emergency department, you improve your revenue capture and maintain ethics. If you maintain your ethics, how you see your patient, how you provide care to your patient, good customer care, you'll have a very good client who's paying, and then you put a mechanism how you can capture revenue. Wherever you do an emergency department, document, bill it, and wherever it's small, but it'll give you something which can make you sustain the emergency department. Another area is about infrastructure and maintenance. I think Dr. said about this. Always, an emergency department must be maintained. When we're talking about infrastructure, including about patient flow, we must have a very good patient flow. Professor talked about triage, treatment, resuscitation, mass casualty, and everything. You must have a very good flow of the patient, where the patient has to start and where the patient has to end. And also, we have to maintain equipment and infrastructure at all times so that all our patients come to the emergency department are getting a good care. But in order to make sure that at least this cycle is well maintained, what can you do? The next slide will answer all your questions. In primary health care, you have to do the following to achieve emergency care delivery. You can say in professional development, we said about identify the champion, train them. Currently, we as the Muhimbili National Hospital, MUHASI, and in collaboration with the EMATI, which is a professional association of emergency medicine association of Tanzania, and other stakeholders, we are trying to train staff in basic emergency care and all other training, which can give you awareness on how you can provide emergency care wherever you are. So you must have a champion. which all the champion has been trained in order to provide emergency care. And as you know that if you have a champion, good doctors, good nurses,
Sorry,
who
Dr.
can provide
Finanga.
emergency care,
Can all the participants please block your speakers, please? Thank you. Go on, Dr.
okay?
Finanga.
If you have a champion and well trained, they will help the emergency department to operate. But the second issue is about the financial sustainability. What can be done in financial sustainability is to formulate and strengthening the mechanism of revenue collection and in the department. In our experience, which we have in Muhimbili National Hospital, we have a system whereby we have a mechanism of collecting a revenue, and all these departments are giving the mandate of ownership. Anybody working in emergency department, they know that this is what we are doing is my property. You own what we have. Things, if you have ownership, you'll collect much. And if you collect much, you will maintain what you have. And we tried to run this, we tried to duplicate the model which ran in Muhimbili, in Bugando, in KSMC, and in Arusha, and in Dodoma, Mbeya. It works a lot. So wherever you have this program of ownership, you will operate an emergency department well. There is an infrastructure. What can be done? Formation of the system of having an engineer, or it's not must have an engineer who's trained. I can give you a very good example, maybe in Muhimbili. We have one health attendant who is also who was given a capacity to know what's going wrong. If there is a tap of water which is broken, or there is a wall which is broken, or a lighting which is broken, an health attendant always fill a job card, and that job card go to engineering department, and he or she make a follow-up that the fault has been corrected. So I can say that wherever you are, even if in the primary health care, if you don't have a biomed engineer, if you don't have an engineer, just train somebody who is just a health attendant to make sure that it's just giving a feedback or report about what's going on. In NHR, we said that it is a specific finance and procurement staff for emergency department. Always, as we said that in emergency department, we must have a very good working financial and procurement system. So you must have somebody who is seeing, always overseeing, how can you buying and how can you control what has been used in the emergency department. As you know that emergency consume a lot of resources, but always you must make sure that at least that resources must be available, save another patient who's coming. And the last issue is your communication. I think always, in order to make a very good communication, what we learned at Muhimbili is to make a regular report and get feedback from staff. Wherever you are, make sure to get a feedback from your staff, your working staff, your peers, and your management. You get at least once a week to have a meeting with your staff, or a monthly or a quarterly, and have a feedback. Those feedback from staff will help you to develop a very nice emergency department which is sustainable. Next slide. And I think there is a lot to be done in primary health care so that we can achieve the goal which the government is aiming to achieve. We, as the pioneer of emergency medicine, especially Muhimbili, MUASI, EMAT as a professional association, and the other hospitals like Bugando, KSMC, what we did, we put some resources which help you to make sure at least there is something for you. And these resources are here for you. Next slide. We developed a lot of courses, and these courses are being provided by our Association for Emergency Medicine of Tanzania. We have these short courses like community first aid, We have a basic ambulance attendant course. We have a basic ambulance provider course. We have an EMF priority dispatch course, and we have an EMS trainer certificate course. These are courses which can help any provider to provide the so-called ambulance transfer or the pre-hospital care services. But we have all these courses which can help anybody, wherever or him or he, to provide emergency care. Of the courses for basic life support, this is American Heart Association certified course. We have advanced cardiovascular life support, is the American Heart Association certified course. We have pediatric advanced life support course. This is also American associated course. And we have basic emergency care, BEC. And we have been running the basic emergency care across all over the country now. And wherever you are in the primary care, you see the team from Muhimbili, team from MRT, team from Bugando, team from KSMC, team from Bear. They are providing these courses everywhere in this country to make sure to all people have been known about basic emergency care. Primary trauma care, this is a UK certified course. Pediatric emergency care, this is our local and the MRT certified course. Nursing training course is the MRT certified course. Basic advanced emergency training course. All these are courses which are short-term courses. They are taking up to 5 days for anybody at any level to be trained, to be competent, at least to provide emergency care wherever he or he is available. Next slide. And now we have all these long-term courses which have been registered at MUASI, and Muhimbili is the training institution. We have a Master of Emergency Medicine, and now we have around 86 emergency medicine specialists across the country, and we have around 46 emergency medicine specialists who are trained who are now at training. And we are keeping saying at primary health care, dedicate or try to find somebody who can come to MUAS to get trained on this emergency medicine specialty. And of Master for Critical Care, we have many critical care nurses who are around the country, and we have Masters of Science in Pediatric Emergency and Critical Care, and of Diploma in Paramedic and Nursing. All these are long-term courses that have been registered to MUAS. But we have all the resources for you. These resources are available for anybody, wherever you are. Just contact for Emergency Medicine of Tanzania. We have these books. It's for you to help anybody you are, and you can access this book and you can read like basic principle of emergency medicine. We have basic principle of emergency medicine. We have skills book. We have emergency medicine clinical protocol. And I think this protocol available everywhere. We have fundamental of emergency care. We have a pediatric emergency care book, basic ambulance provider book. And the next slide, we have a basic principle of triaging. We have a basic ambulance attendant book, basic nursing book. All these books are available for all primary health care to make sure that at least they can get this resource and they can train others and they can learn something from us in order to pioneer what's going on. Furthermore, by using the Emergency Medicine of Tanzania, we have social medias like YouTube channel, we have an app, MRT app. All these resources are available for free. You just go to your smartphone, Google Play, and download the MRT app. You'll find all these resources for free, and you can read or you can do wherever you want. Next slide. But what we are trying to do, we divided the country in 4 zones so that we can support you wherever you are. We have our lake, we have our eastern zone, where we always provide training in primary health care by using people available across the coast. We have the northern zone, we have our TOT at the northern zone, who are there to provide training for those areas which is available at this zone, and our base is at KSMC. We have our central zone, which are taking care of all central regions and our base is at the Benjamin Mkapa. We have a lake zone, our base is at the Bugando. They are taking care of all lake zone regions. We have Northern Highland zone, all regions and the districts at these regions. They've been taken care by this area, which is our base. It has the Mbeya Zone Referral Hospital, and we have our southern zone, which their base will be put at Mtwara, where we'll make sure that at least we are providing the same. We are providing training wherever you are, and make sure that all primary health care can be reach in all primary healthcare facility. Otherwise, I think because of time, we know all in all, emergencies can occur anywhere, everywhere, in any place, at any time. So we make sure that at least get prepared and we are ready to support you wherever you are. Otherwise, thank you, moderator, thank you, participant, and thank you, my colleague who started to speak. We are ready for your question.
Thank you. Thank you very much, Dr. Funanga, for that excellent presentation. And for the participants now, as you have seen, you have heard from Dr. Sonda regarding the infrastructure which is being put. You have heard from Professor Save what is basically meaning of emergency medicine, what are the principles of emergency medicine, and how do you actually put the infrastructure and the organization in place. And then you heard from Dr. Finanga, the practicality of putting this emergency in place, what the resources are available, all the support available, and all the training available. So it's a 360-degree circle of all the emergency care support which can be provided you are interested and you are committed to do something, as Dr. Finanga said. So we'll open the floor for questions for the next 10 minutes. If there are any questions, you can ask the question and then the respective speaker can answer. So if there are any questions, please raise your hand or you can start asking the question, please. If you are shy to talk, you can put it on the chat box. Any questions, please?
There's a comment.
So either the presentations were very crystal clear or you probably did not understand. It's one of the two conclusions. If there are no questions, and I hope it was crystal clear.
Sorry, Mr. Chairperson, there are 3 hands in the, I could
Yes,
see the.
please. Yeah. Can we have the first question,
There is a hand.
please?
Maybe Dr. Lillian, and then Said, and then Raymond, I could see their hands.
Yeah, so Dr. Pius, can you handle that? Because I can't see it from here, from my side.
Okay, we have Dr. Ririan Mbuni, but again, you have Dr. Saidi Maya and
Dr.
Raymond Bandia.
And Isihaka.
Isihaka again. So we have 4
Okay,
hands.
so
raised.
can we have Dr. Lillian, please, to start?
Thank you, moderator, for giving me a chance. I'm Dr. Lilian Mbuni. I'm working with Temeke Municipal Council. I'm just here by sharing my best practice. First of all, I'm so humbled to present in my best practice in front of my teachers, Professor Henry Sao and Dr. Juma Mfinanga. Before working with Temeke Municipal Council, I was the District Clinical Services Coordinator at Biaramulo District Council. And by the same time, I was the medical officer in charge of Nyakanazi Health Center. For all who know Nyakanazi is the junction, the highway junction, the roads connecting Rwanda, Kahama, Kigoma, and Kagera. It's a very highway. I just want to share my basic practice because when I was working at the health center, there was no emergency room no emergency department, but the road was very busy, a lot of accidents due to the business of the road. Also, that places the government big projects, the power stations. So there are builders working with the power stations, whereby getting mass casualty was just anytime we used to get mass casualties. So the thing I did, I just improvised one room. I put it six beds with their mattress, and I took the emergency protocols from the Muhimbili National Hospitals. I magnified them and then I put them on the wall, and I developed a SOP for management of trauma patients, and I displayed them. And with time, we used that room as an emergency room, and it worked, and it helped us a lot during mass casualties. So by the so doing, I would like to advise the government to consider Nyakanazi Health Center due to its locality and the highways and the casualties which happen there, to consider it in the plan of building an emergency department. Thank you.
Thank you very much, Dr. Lillian, for sharing your experience. And as you have correctly shown, that with a very small step of putting the protocols and putting the beds there, you were able to bring about a change. Thank you very much. Dr. Saidi.
Thank you very much, Mr. Chairman. I'm Dr. Saidi Maya, medical officer in charge of Mafia District Hospital. First of all, I would like to thank the government for the ongoing improvement in emergency and critical care. We ourselves have been considered for an emergency department as well as an intensive care unit. What I would like to stress is, I guess we have to make a really realistic needs assessment in these emergency departments, as well as the different needs of different areas, so that as we were talking of the transport part of the emergency care, not every place is conducive for moving the patients from one place to another very easily. Some are islands, some parts of our countries have got infrastructures which are not very good. So I was stressing that with the ongoing improvement in primary health care, so we do the needs assessment, as I believe that there are some places they need to be like semi-self-reliant in case of emergencies, because there's no chance for some places like the place where I am. If you get an emergency that needs to be moved, like maybe to Muhimbili or any other major hospital in the mainland, you will need, like, if it's in the evening, you have to like sustain the patient until the next morning, or otherwise the patient will die in the middle of the night. So some areas have to be considered as like connections to the big emergency care providing hospitals, but some areas, though being small, they need to be considered as very self-reliant in handling those types of emergency cases.
Thank you very much, Dr. Saidi, for your comments and for your observations. Does Dr. Mfinanga or Professor Sawe, would you like to respond to any of those comments which are there from the two previous speakers?
Yes, thank you, Mr. Chairperson. I'll respond to the second one, which I totally concur with Dr. Said's observation that our terrain, our country is big, and there's definitely a need to have a tailored approach to pre-hospital services. However, we also want to be cautious that it's not everything that can be managed in an emergency department. The emergency department's responsibility usually ends up in stabilizing the patient. So this typical example would be even if it's Mafia or anywhere in the country. When you have somebody who have a complicated injury that probably needs advanced neurosurgical care, there are probably only 3 areas in the country where that service can be provided. And probably Mafia is not that area. And so if you have that patient, definitely a pre-hospital service will be done after the patient has been stabilized, but definitely we need to medevac that patient, whether it's by air or by ocean. So yeah, it's a combination of both. You wanna have an emergency department that can give everything to emergency, but also you wanna create a referral pathway. When this happens, how do we medevac the patient quickly from Mafia to the nearby facility? It's a standard practice across even systems that have evolved more than ours. Thank you.
Thank you very much, Professor Sabe, for that one.
Moderator also can add it to a comment for Lillian. I think first of all, what Lillian said is very nice thing. I think she provided the experience, what she did in Nyakananzi. But I think is what we are saying that what we started, I think we did the so-called Tanzania Emergency Care Capacity Survey in 2011. And what we found, there is nothing going on in the district hospital at the level of the district to the level of the region in 2011. But when we are here today, we are talking about more than 80 emergency departments in district hospital, significant improvement. And all regional hospital, more than 26 have an emergency department. So I will congratulate and saying thanks to the government what they did. And if you come now to our second Tanzania Emergency Survey, which is ongoing, we'll find there is a lot of significant what the government has been done. But what you can say, we as the champions of emergency care, when what Lillian she did is what everybody has to do. Wherever you have, utilize it, but contact us. We can support you wherever you are. And those protocols which Lillian used, they are very available to anybody. Wherever you are, contact us, we'll give you a protocol. Sometimes for free, sometimes we give you for free. We sacrifice this for free and we give you how can handle emergency care. And we are looking forward, after finishing with the government, the ongoing emergency care in the council and the district hospital will come with another modality, how we can support the health center and the dispensaries. We have an ongoing pilot for some dispensary and health facilities to see which the modality will advise the government to run the emergency department at that level. And furthermore, to give you support, we are looking for the so-called emergency toolkit. The emergency toolkit is about having a resuscitation room, having a checklist, like what Lillian has spoken about, having a protocol, and having a documentation chart. So I think with time, we'll provide you with all this emergency toolkit for you to provide the better emergency care. Thank you.
Thank you, Dr. Mfinanga, for that explanation. The next speaker is Raymond. Raymond, do you have any questions?
Yes, so thank you. So mine is Mayana. So I was just wondering, as much as the emergency services, as you say, Dr. Mfinanga, is expanding throughout the countries, but we have seen a lot of ongoing road accident recently, but this is not a recent occasions, but they've been occurring here and there. So I was wondering, do we have any specific, probably public and public health intervention, especially on capacitating the communities on the pre-hospital care? Because I think most of the patients, we are losing them on the way to the hospitals. Thank you.
Okay, Professor Sabe, would you like to take that question?
Yes, thank you. So yes, definitely. I think I'm aware that the government is working really hard. There are two aspects to this. One is definitely general public awareness, the intervention measures that needs to be undertaken by the Road Safety Council. That includes public awareness, control across the accidents, and so forth. So that's one piece of it, which is preventing the accident from happening. But there's another piece to it, which is now the accident has already happened. What do we do? There are three parts to that. One is, how do we safely get the patient to a health facility? And that's the pre-hospital part, which we spoke about in detail, improving the access to getting the patient to the facility as quick as possible. But number two, making sure when the patient gets to the emergency department, the care that they receive is appropriate, timely. And then if they need referral, that referral is provided in appropriate time. And then number three, which is mostly down the road, is the definitive care part, which involves in-hospital care, which is operations. So if it's orthopedic care, it's neurosurgical care. So all of these three components will definitely help. But we want to separate the two of like public awareness, prevention for injury, but they will still happen, unfortunately. And then what do we do about it? Which I'm aware that through this initiative, the government is also working hard to develop a system that can help deal with the pre-hospital component. While I'm not the person to speak about it, but I'm sure the government is doing something about that. Thank you.
Thank you, Professor Save. Next question is from Isiahaka.
Thank you, Professor Kaushik. I hope I'm heard. So my name is Isiahaka, and I would like to congratulate the team for organizing this beautiful webinar. The government, of course, this massive scale up of emergency services, to sub-national level. It's really massive. And my colleagues, Dr. Juma and Professor Henry, for their commitment to actually overseeing and provide technical support, to ensure that these services are rolled out, across the country. So mine was just one question I wanted to learn from the experts here. Are there any initiatives that we are currently implementing to ensure that the same expansion and improvement you are making in the public sector is also happening in the private sector?
An important question. Professor Save and Dr. Mfinanga, would you like to reply there?
I can reply that what we are trying to do is like, sometimes is maybe Dr. Sonda will talk about that, what's being done is going, but in our aspect, especially for we as a supporter of what government is doing, we are developing the capacity building across all over the country, regardless whether it's a public or the private institution. As we know that wherever a patient gets an accident or get a diarrhea, a kid get a diarrhea or a fever, he or she will show at the nearest health facility. Our training and capacity building doesn't segregate either the hospital is a public or is a private. We have been doing this training across all of the country, regardless is a private or government institution. All this is to make sure that at least what the government is doing, we are supporting the initiative of the government to support the healthcare deliverable and make sure that we are reducing the burden of illness and the death in capacity building. For infrastructures, I'm not the person to talk about that. Maybe Tamisemi management talk about that. But in developing capacity, we have been doing a lot in a private hospital and the government. We don't segregate either is a government or is a private. When we are calling people for training, wherever we go, we take all hospitals across that area, that locality, to train them in providing emergency care.
Yeah, thank you very much, Dr. Mfinanga, for that one. And I think private sector needs to come up with a strategy, how they are going to establish and how they are going to basically tap the resources available for the training and what you mentioned. I think that's what the private sector needs to do. Yeah. So the next one is Dr. Fred Shayo. That's the last question. And then I've got 3 comments from the chat box, which I'll present to all the speakers. Yeah, so Fred Chayo, your question, please. Fred, we can't hear you. You are muted. We can't hear you. We can't hear you. Dr. Shayo, we cannot hear you. We are unable to hear you. While you sort out your mic system, I'll just bring about 3 comments which are there in the chat box. One is to Professor Sawe and to Dr. Finanga, that there are 86 EMDs you mentioned, and those who have been trained. And the question was that how are they distributed all over the country? Is there a certain area where they are many more concentrated, or how are they equally distributed all over the country? So that was first checkbox comment. The second one was primary care, which you, Dr. Finanga, you answered very well, that you are now already doing a pilot and doing an assessment for the health center and the dispensaries, and you'll be rolling out based on your assessment which you have done. That you already answered. And the third thing was there any role for people who do not have emergency services or training of telemedicine if required, as and when required? So those are the 3 things on the checkbox. So Dr. Juma and Professor Sawe, whoever wants to take those 2 questions, telemedicine and the distribution of the emergency medicine physicians.
I can speak. Oh, go ahead, Juma.
Okay, I can speak about I can speak something, and then Professor will add up what we are doing. What we are doing about the emergency medicine specialists available, we know that this number is not yet enough for the country. What we are trying, we can say we are working with the Ministry of Health and TAMISEMI to make sure that we are adding more emergency specialists to the area. But all in all, when we started in 2010, 2011, we were trying to encourage, like if you have a facility, maybe you are in Mount Meru. I remember one of my slides, I said about the champion and the HR development. You as in charges of the hospital, find one champion and bring to us. We'll train that champion for you. And if this is your employment, it'll come back to be in your facility. Because all this we are talking about, these are people who came from regional hospital, zone hospital, and all of them have been returned back to their area. And as we are talking today, in Muhimbili, we have only 8 specialists out of those 86. So majority are working the region and zone hospitals. So we are sure that even you at that primary health care facility, and I found a lot of people are coming from the district hospital, and I've been talking this with the Dr. Sonda and the Dr. Ntuli, even Pius. Try to look at it. We are developing a champion from our facility. If take somebody from Lindi and came to us, we'll train for you and we'll encourage him to go back to Lindi, and we'll give him all requirement and all support to develop capacity in emergency care. I can answer that one in distribution. And also about the rural medicine, fantastic, yes. We have that system. I remember those who joined during COVID-19, during Ebola, we had a so-called ECHO. We were training more than 500 people per session. So there is a big role for telemedicine, and currently the Ministry of Health and TAMISEMI, they are putting ECHO to everywhere. There is spokes and the hubs all across the hospitals. Telemedicine, we are ready to support everybody training in telemedicine. Fantastic, we can do that to support you wherever you are by using telemedicine. But Professor, can you add something about that?
Yeah, Professor Same, let's hear from you the last words and then we'll close the session.
Thank you, Professor Kaushik. I think Dr. Juma have answered it well. Just to put some numbers into context, I think we are about 50% distribution across the 28 regions in the country. So just very quickly, based off my head, I know out of the 28 regions that we have in the country, just making sure my number is correct, we have an emergency physician in Arusha, Manyara, Arusha, Montemeru, Manyara, Morogoro, KSMC, Iringa, Mbeya, Katavi, Songea, Benjamin Mkapa, Kigoma, Dodoma, Tanga. So you'll count, you'll see that we are about 14 emergency physicians in those RRH out of 28, and that's to speak on a public facility. We also have colleagues in private facilities. We still clearly know that there is a need, and the current training that's ongoing for the ones that are in the training will help balance that number. So as Juma said, the most important thing is not to look at the 3 years of training, is to encourage the people to come and train, given if it's within the training plan of the facility. In this number, we'll close the gap as soon as possible. But I think given the youngest, given the profession being very young and being able to attain 50% in such a short period is a really a big part to the back of the government for supporting and making sure that we are able to reach as many people as possible. So if you're in Kigoma now, you have an emergency physician. If you're in Katavi, you have an emergency physician. If you're in Songea, you have an emergency physician. And all of these are areas that are considered remote. And I think we have few, maybe 13 regions to cover in terms of the RRH. And then we look into the council level, which is also another big undertaking. Otherwise, I'd like to thank you so much, Mr. Chairperson, Professor.
Thank you very much. And with this one, I would like to end this session. It has been an excellent session, wonderful, excellent information, infrastructure, how we are doing, what we were, how we are doing, and where we intend to go. And I think it summarized the efforts and activities which are being done by TAMISEMI to ensure that emergency care is available at the lower levels of care. I would like to thank Dr. Sonda. I would like to thank Dr. Juma Finanga and Professor Sawe for excellent presentations. And I would like to hand over back to Dr. Pius for his closing. On my side, thank you very much for giving me this opportunity to share this session. It was a very fruitful. And above all, I would like to thank all the participants for staying for more than 2 hours on this session and actively participating. Thank you very much. One last question was, Dr. Pius, you need to find out is that a lot of people are asking in the chat whether these slides would be available, resources would be available in what way.
So, ladies and gentlemen, on behalf of the PRAJ, it is my honor and pleasure to appreciate every one of you. But in a special way, I would like to appreciate Professor Kaushik for the fantastic moderation of our today's masterclass. But again, I would like to extend my sincere appreciation to Dr. Juma Finanga and Professor Sawe, who are the gurus and the fathers of emergency medicine in Tanzania. But again, I appreciate Dr. Sonda from PRAJ for a fantastic presentation. That is the eye-opener in the case of emergency facilities and exactly what is really needed in the case of basic emergency care. So thank you all the participants who attended our masterclass today. But before I close, I saw the presence of Dr. Paul Chaote, who is the Assistant Director of Health Services at the PRAJ. So please, Dr. Chaote, I take this opportunity to welcome you if you have anything to say or a closing remark. before we end our session, and we have recorded all the participants with their respective names for the preparation of the CPD award. And after this presentation, we'll make sure the slides will be available for your revision in your respective areas. We share them in the groups through the RMOs, the DMOs, and the facilities in charge. So, Dr. Chaote, you're welcome.
Thank you very much. Kwanza kabisa ni shukuru sana Profesa Kaushik kwa kutuwezesha kumoderate session hizi. Nawashukuru sana presenters wote, Profesa Andy Sawe, Dr. Juma Mfinanga na Dr. Sonda pia kwa kutuendeshea mada hizi ambazo mmewasilisha. Kipekee niwashukuru sana Dr. Mfinanga na timu yake ambao umepionia na kuspearhead uwepo wa EMDs katika maeneo yetu, na kama ambavyo tumesikia imeelezwa juhudi mbalimbali ambazo zinaendelea kuchukuliwa na sekta kwa ujumla kushirikiana na wadau mbalimbali, angalau tumeweza kufikia hatua hii. Niombe wenzangu wote ambao tunahudhuria session hizi, hasa wale ambao tuko kwenye vituo moja kwa moja, tuone tuna jukumu letu mbele yetu la kuhakikisha kwamba huduma sasa hizi zinatolewa. Na nishukuru waliweza kushare experience ya kuimprovise hata wale ambao bado hatuna. So bado hatujaweza kufikia vituo vingi, na hasa vituo ambavyo kwenye highway. Matarajio yetu na matamanio yetu kuona kwamba vituo vyote kwenye highway vinakuwa na huduma hizi za dharura, sababu tunajua kabisa how important tuseme zile golden hours katika kuweza kusave maisha ya wahanga wa especially ajali. Uwepo wa vituo hivi vitasaidia sana. Kwa hiyo bado tuna kazi kubwa ambayo iko mbele yetu, nasi tutaendelea kuhakikisha kwamba tunashirikiana na wadau wote ambao wapo kwa ajili ya kuboresha huduma hizi. Basi baada ya haya niwashukuru sana kwa wote ambao tumeweza kushiriki, na tuombe kuendelea kusisitiza wenzetu wengine kushiriki zaidi katika session zinazofuata. Asanteni sana.
Asante sana Dr. Na next session itakuwa ni next week. We will skip the next week, then after the next week we'll have our other master class. Kwa hiyo tutakuwa tuna skip wiki moja ili kuwapa participants muda mzuri wa kushiriki na wa kujiandaa zaidi. Otherwise tunawashukuru sana na tuwe na jioni njema. Asanteni.
Asante. Asante.
Thank you very much.
Thank you very much.
Thank you.
Thank you very much.
Thank you.
Thank you.